building trust and coordination and activation within the Medicaid population. But even deeper than that, beyond processes and programs, are the people, right? And people that are navigating a complex environment, oftentimes at some very challenging moments in their life. And center to that and what the foundation is really building trust, which is beyond just a single outreach or a single program, but really those meaningful engagements and repeated collaborations that we're having with our members. And on top of that is just the ability to navigate the system and to have multiple outreaches and touch points thrown at them from different payers and organizations. So we're going to talk today about how we can move beyond just the transactional outreaches to members and really focusing on building relationships with them, collaborating more across systems to make a difference and help improve health outcomes for those that we serve. So thrilled to be here with our panelists and to listen and learn from them. So to get started, if you all just want to share your name and organization and what you do. Whitney, thank you. Can you guys hear me? No. All right, is this better?
Yeah.
Okay, awesome. Well, thank you so much, Whitney, for moderating, Catherine and the association for hosting this event and this important conversation centered around member engagement. My name is Lindsay Ahlvers. I'm the Director of Client Services at Vheda Health. Vheda Health is an outcomes and analytics platform that really focuses on partnering with Medicaid, Medicare, and SNP health plans to reduce avoidable medical spend. By really outreaching and engaging with these high-risk members, not only earlier in their healthcare journey, but intentionally, we really focus on reducing ED visits, hospitalizations, as well as readmissions. And with over 12 years of experience in this space, we have an average of 80% member engagement. And really excited for myself and the panel to continue the conversation today on how we focus on that intentional member engagement to really drive these outcomes that everybody is looking to achieve. So thanks again for having me here.
Great introduction. My name is McGuire, and I'm with the UK Kentucky Home Place. I've been a CHW, which is a community health worker, for 18 years now. And right now I'm president of the Kentucky Association of Community Health Workers. And what that is just an association for the CHWs, led by the CHWs. Gives them a place to gather, join together and share their resources, other agencies, what they're doing. And we meet every quarterly, once every 3 months, and we have an annual conference coming up this August 26th and 27th, so I'd love to see some faces there. But as a community health worker, I don't know if you know what that actually stands for or whatever, but it's a trusted individual that in the community that knows that community's needs and the resources. We're boots on the ground. We're out there in the communities. We form trust and engagement with all networks. And it's not a competition. We're there to help each other. So I appreciate you asking me to be on this panel. It's the first time I've ever done this. I've done conferences before, but never on a panel discussion. But thank you, and then I hope I can answer lots of questions for you.
I'm really grateful to be here this morning. Thank you so much for inviting Samaritan to be a part of this. Part of my notes, my flights afforded me just a couple hours of sleep last night, and this is a really important conversation. My name is Jeff Mays. I am the CEO of Samaritan. Samaritan is a support platform that helps health plans, providers, public sector partners in turning care plans into real-world follow-through for people who are wandering near the street, to help them maintain coverage, to stay connected to care, and to take the meaningful steps that they need to take to create stability for themselves in their housing, in their health, in their income. It turns out that if you don't know where you're going to sleep safely tonight, that's really bad for your health, right? The healthcare system is really good at identifying what the next step should be. It might be a behavioral health visit, a housing referral, being prepared, getting the doc ready for a redetermination. So the healthcare system is really good at that, but the hard part is how do you stay with that person every day while they're trying to break down some of the barriers that are helping keep them making progress, especially when they're in a traumatic situation like being houseless. So we close the gap between a suggested action and a completed action. We help frontline care teams establish small, member-led, bite-sized goals. And then we have some tools that help to reinforce. So basically we provide two types of capital. One is financial to help someone break down some of the unique barriers that they have, and to help them feel achievement in some of the action steps they're taking. And then we also wrap them in a social home or social capital. And what that does is provide them with the encouragement and support that they sometimes need to make the progress that they want to. So things like fighting the isolation, loss of motivation, and self-doubt that instability creates.
How important is trust in really driving that member engagement and activation?
Absolutely. I love that question because I truly believe that trust is foundational when it comes to building that engagement and to really improving healthcare. As it was mentioned that if a member doesn't know where they're laying their head at night, it's hard to care about what their blood pressure is, what their weight is in any given moment. So really focus on connecting with those members intentionally to understand where they are. To understand that not every single member is on the same health journey. Not every member is on the same socioeconomic journey. So really working to get to know these members at a core personal level. And I think really being able to humanize healthcare again is really key in setting that foundation to the outcomes that we're all looking to drive, the outcomes that we're all looking to improve. What we found is that building trust and really working to get to know these members, get to understand who they are, allows for that activation to really easily follow. At that point that a member now trusts our program, they trust us as an extension of their health plan. They're seeking care more timely. They're seeking care in intentional ways and really, again, looking to drive down and decrease that unnecessary utilization. And again, for reasons that we're all here to really improve those overall outcomes. So I love that question, and I think it's hard to build the engagement that we're going to be talking about during this whole panel without that trust. So I think that's where we have to start.
And even though data and AI and all those capabilities, they're here and it's probably here to stay, there's still a component of that human piece that probably will never be replaced. So Angela, really curious to hear your thoughts on that piece that AI will never be able to take over, especially in light of community health workers.
Yes, that's a good question as well. IT can tell you how to do it. You can Google anything, you can do all data, is great, but you need somebody that knows what they're going through, what they're feeling. It may tell you how to open the door, but it doesn't talk you through going through the door. So I just want to add in one of our last director of UK Center of Excellence in Rural Health, Fran Feltner, always said, if baby needs new pair of shoes. Okay. Say it again. Yeah. Hello.
Check.
Just use us.
Hello. Anyway, I can holler. If baby needs a new pair of shoes, mama's not going to go get a pap smear.
bottom line. They come in, they want, when they're looking for the insurance, they come in, a lot is just, what kind of perks do you have, where can I get the most kind of thing. But you have a lot that really want that health care, but they don't have the means to go get it. Transportation insecurities, housing insecurities, food insecurities. So being a person and being understanding and opening up to them, you gotta show up every time, you gotta follow up every time.
Like, what does that meaningful engagement look like with that population?
I think we have to define engagement in context. Progress is going to be uneven for the folks that we serve. Sometimes progress is a medical appointment. Sometimes it's just one honest conversation. Sometimes it's somebody who's showing up after a few weeks of silence because the barriers that they were overcoming became a little smaller, and the outreach felt safe to re-engage with. And there's the operating side as well. I think we have to be careful not to confuse activity with progress. Volume of outreach, documented referrals, activity with progress. These are all things that I've seen look productive on paper, but they're really not changing anything for the members. So the questions I ask are pretty simple. Did this person move one step closer to health, income, housing stability? And do we make that step easier or harder?
Are multiple touch points through various programs and teams that happen. So when we think about competing for a member's attention, curious, Jeff and Lindsay, your all's thoughts for how we can come together instead of having multiple disconnected outreach campaigns and coordinating more together as a system.
Kick us off.
Yeah, I mean, I think the first thing is decide the one thing the member needs to do most right this moment. Route that ask through someone they trust. That could be a care manager, it could be a provider's office, a community health worker, a community partner. We also need enough internal discipline to not hit the same member with 5 priorities. So it could be that somebody is ready for redetermination and they also need to get to their primary care doctor. You don't need perfect coordination across the system. You just need to create clarity for that member rather than some of the noise. So I would say pick the immediate priority, which may be like protecting their coverage. Make sure that the member's connected to a care manager that they trust. Equip that person to carry the message and to help them see it through. And then once the next step is locked in, then you can move on to doing something like doing the primary care visit. They don't all need to happen with the same amount of urgency. And that's how I think when I'm going through my day. I have a lot to tackle. I'm just taking these bite-sized pieces. So I said that's probably the best way to coordinate is to break it down to the simplest component. Think about it like your members think about it.
Jeff, just to kind of piggyback on that, I love that underlying theme of simplifying healthcare. I think it also goes back to ensuring that the outreach is intentional and not transactional for these members. We've talked about understanding where the members are in their health journey, where they are with any sort of SDOH needs. That could also be understanding where a member is following a natural disaster. Something that really kind of came to mind as we were kind of talking through this panel and the engagement aspect was, last spring at this time, Vheda Health partnered with one of our health plan companies, partners here in the state of Kentucky, following a string of disastrous tornadoes over a short period of time. I believe it was last April, to really connect with our health plan in near real time to understand potential members that could have or potentially been affected by the tornadoes. We ended up identifying 105 members who were medically complex. They were enrolled in the Vheda program because they were high risk. They had diabetes, heart failure, COPD, you name it. In connecting with these members that same day, I'm proud to say that we connected with every single one of those members to understand where they were. Were they in need of care? Were they in need of medications? Were they displaced because of tornadoes? Were kids' schools potentially, were they displaced there? Just again, understanding everything that was going on at that time, and just kind of bringing it back to ensuring that every single outreach is intentional. In that moment, members didn't need to know what an additional value-added benefit was that they had through their health plan. While there's so many wonderful benefits that the plan provide, what they needed was to be heard, to be seen, and to be connected to resources timely.
So I think you all did a great job summing all that up, finding someone that's in the community that they trust. So it could be if we're wanting to push out messaging, leveraging providers or folks like community health workers to deliver that message, but also being really aware of what's happening in their life, in their communities at the time, and making sure that messaging is really appropriate. Angela, you do a great job with like personalization, like your patients know you, love you, and your teams. I'm curious how you balance like the scalability for thinking through. There's a lot of folks out in Eastern Kentucky that need needs, that have lots of needs, and then balancing that with scalability, but also not missing that personalization piece.
A lot of the challenges we've all had, the same challenges, and you just bring that individual personality to it, and you have to form a rapport with them. They have to trust you to tell you some of the stuff that's going on in their lives. So that's very important. If I see them out, I mean, I can't get to the grocery store without 10 hugs. But I'm no longer with client care at this time. I took another position, but I miss those people. But they're your lifelong friends. So to have one individual from your organization to reach out to them and build that rapport and build that friendship, I feel that that's the most important, because they want to be trusted. They want to trust you. They want you to know that they are somebody that matters.
The folks that have needs.
Yeah, I'm proud to say that a lot of the partners that we work with say that the Samaritan members are the most proactive. Where they used to have to chase somebody down, now that person is coming to them to brag on the fact that they achieved their next step. They wanted to get more reinforcement so that they could define and to tackle the next step. Most of these folks are, but for the grace of God, you or me, they really do want to help themselves. And if you just clear the barriers out of the way, they'll not only engage and activate, but they'll thrive. They'll self-actualize. For me, real personalization means, and I'm going to sound like a broken record, that the outreach reflects what the person is actually working on, who they trust, and what a realistic next step is for them. You scale that by building the relationship layer, and I know that's expensive to scale. Automation can handle things like the consistency things, right? Like a reminder, tracking, flagging who's falling behind. But the humans handle the moments that matter the most.
Creating engagement strategies that are really intentional. You talked about intentionality at the beginning rather than the high volume.
I know I've already talked about kind of that intentional outreach, that intentional connection with the members, understanding where they are in a time of crisis. But also being intentional is understanding that not every single member needs to be connected the same way. Not every single member needs the same amount of outreach and touches. At Vheda, we really focus on using clinical data as well as risk data to really focus on that earlier intervention in that meaningful way. Making sure that we are connecting with those members in ways that's most relevant. If we really focus less on tracking the number of touches and tracking the impact of the touches that we've had. I think we'll continue to see those outcomes snowball and improve. For us, really making sure that success, again, is not measured on how many calls we're making, how many just connections to check the box, but making sure that it's really intentional in improving set outcomes that we're looking to drive with our health plan partners, whether it be for members enrolled in a chronic condition program, behavioral health, high-risk maternity. Again, I think just understanding that every single member just it truly does need something different. And Angela, I think you said it so best that technology is great, AI is great, but you still need that human component, and technology doesn't know how to get to know a member, how to understand a member and their needs, to really make sure that the members are overall just having a better experience, and then in turn that our health plan partners are also having a better experience.
I want to add, sometimes it takes just holding a hand. That means a lot. Just hold guide them with you. Like I said, you can read it how to do whatever, but sometimes you have to just hold that hand, give them that courage to do whatever. And you don't get that from the computer.
It's, I think, also helping build that trust, building their own capacity to be like, I can do this. This really isn't that bad. It's not that intimidating. I can do this, to help get them to the next step in the health journey too. So I'm curious to hear from each of you. I always like to end on an action item. If there is one practical step organizations in this room can take tomorrow, that's okay, to engage some of these more hard to reach populations, what would the call to action be for folks in this room?
I love that question. I really love ending a panel on a call to action. We're all here for the same reason. We're all here to improve engagement with members, to drive outcomes. I think my call to action would be to simplify healthcare, to simplify the member's experience. I think too often, and when you kind of started this out by saying, members have various ways in which they're communicating, various apps to download, various numbers to call at different times of days, whether it depends on completely different needs that they have. So I think the engagement isn't about doing more and pushing more programs, but again, doing that with intentionality. So really making sure that we're simplifying healthcare for these members, again, to improve their experience, to improve those outcomes, not only for the members, but for the providers and for health plans alike as well. I think that's what we all need to try to do together.
We all say that CHWs is the best kept secret. So if you are a provider or a big organization, think about getting that community engagement person. Have them find out where your CHWs are in your communities and let them know what you offer. Don't just be like, oh, they can read it online or whatever. Let them know. They need to know these things. And time just, it gets so much in such a short time. We need to hear from you all. Tell us what's going on, what you offer, what can you do to help our clients. So number one is meet them where they are, get out in the public and know them, and find your local organizations that can help you find other community organizations.
Every one of you in this room is here because you've got positive intent. And we all represent different parts of the ecosystem. There is no shortage of human and program resources that are available to these people who are unstably housed. What's lacking is the capacity to access them, to break down these barriers that are standing between them and the next step, that ultimately gets them to the macro things that we all want for them, like a mammogram or going to see their provider. It's complex, even for me. And I have a home and a family and a support network. It's really complex. So my call to action for you is we got to start smaller. Go back to the basics. Pick one cohort, okay? The population that you most need to reach and haven't been able to reach, ask one question. Well, it's a compound question. It's actually two questions. Who do you already trust? And how are you resourcing those people? Then you have to put real support behind those relationships. Strengthen the trust layer that's already there. I think that's the call to action, is break it down, tackle one cohort, find the people they trust, and make sure you're making that journey easier.
So finding the cohort, find the people that they trust, starting small, right? Finding CHWs out in the community, sharing resources, and just simplifying healthcare overall. All right, well, we've got time for some questions, so I'd love to hear questions from the audience for our panelists.
That are not having cell phone access. So by deploying them a smartphone that comes with a SIM card that is system agnostic, so it's not necessarily T-Mobile or Verizon, but it's picking up on the nearest cell tower, ensuring that members always have that access to care. Also on the smartphone, we're customizing the home screen with our health plan partner. So putting all of those apps, those tools, those resources, those phone numbers on the home screen to make it easy for the member to navigate, easy to drive them to all the wonderful resources and value-added benefits that are available. And then taking it a step further by understanding what are their condition needs and also deploying the biometric devices based on their specific condition or multiple conditions, as many of our members face 2 or 3 chronic conditions. So again, simplifying, putting everything in a box, sending it directly to the member, allowing them to open it up, turn it on, and begin utilizing those resources. I think really kind of brings everything full circle, and again talks about the simplification, talks about overcoming barriers as well, and then being able to put resources like Samaritan and connecting members with their CHWs is extremely powerful to make these members like you and I and give them those resources.
I just want to add one thing to that. I know everybody in this room is a decision maker. Most decisions are not independent anymore. They're made by committee. You're very risk averse. You need your decisions driven by data. And the partners up here, we all have really strong empirical evidence of success. So when you're thinking about where you deploy, to my point about how are you arming those trusted people with the resources they need, lean in on the data, ask questions about, so in our case, more than 80% of all members who get a Samaritan membership engage at every single partner we have across the country. No partner is less than 80% engagement. These action steps, they're completing between 85 and 95% of these action steps on a daily basis. The result of that is when you do the right thing happens. So to your point, we have data that shows that it's not just about engagement, it leads to the outcomes that we're looking for. So reduced avoidable ED visits in inpatient stays, increased visits to the primary care doctors. Like I said, there's a lot of data that's available, and I would just ask you to challenge us to prove that what we're doing is actually working, particularly here in Kentucky.